Hello everyone. Today I will be giving a lecture on Alzheimer's disease, which is a part of neuropsychology paper for M.Sc second semester, Department of Clinical Psychology students. So my topic is Alzheimer's disease, which is also a neurocognitive disorder. So what exactly are neurocognitive disorders? They're also referred as dementia in DSM-5. It is not a single disease, but a collection of disorders that can cause damage to the brain. So the damage to the brain can in turn cause cognitive decline in individuals. All neurocognitive disorders, or NCDs, imply an acquired cognitive decline in one or more cognitive domains. So what are these cognitive domains? They may be in the area of memory, they may be in the area of reasoning, thinking skills, problem solving, and several others. Ultimately, they may also affect behavior of a person, the feelings of a person, and indirectly affect relationships of the individual with other people as well. So there are major and minor neurocognitive disorders, or NCDs, depending on how severely the symptoms impact a person's ability to function independently in their everyday activities. That is, it impairs their ability to solve everyday problems. It may have an impact or it may damage how they're performing their everyday activities or daily activities of living, such as wearing clothes, washing one's face, eating food, or interacting with others. There are different types of neurocognitive disorders, and these different types of neurocognitive disorders may be due to different factors. So what are these factors? The first one, they may be due to problems in endocrine conditions. They may be due to thyroid problems. They may be caused due to nutritional deficiencies, vitamin deficiencies. They may be also caused due to the presence of substance abuse, whether it be alcohol and other drugs. They can also be caused due to head injury that a person has experienced. So these head injuries can either be closed head injury or penetrating head injuries, which I will explain in other lectures. They may also be caused due to infections such as sexually transmitted infections, and may be caused due to the presence of virus, bacteria, and others. So what exactly are Alzheimer's disease? It was coined by Alois Alzheimer. He first described the condition from a case he saw way back in 1907, and later this disorder assumed his name. It is by far the most common and best known of all the dementias. Alzheimer's disease accounts for 60 to 90% of all cases of dementia, followed closely by vascular dementia and other dementias such as dementia with Lewy bodies, Parkinson's disease, frontotemporal dementia, Wernicke-Korsakoff syndrome, and others. Alzheimer's disease is a progressive cortical dementia, that is, it affects the cortical region of the brain, and also it is irreversible. That means we cannot reverse the damage that is done to the brain. And thus, when these two things occur, it results in an inevitable decline. All medications given for Alzheimer's disease patients are not for curing this disease, but rather for slowing down the process of cognitive decline. As we've already mentioned earlier, it is an irreversible disease. It is also considered a neurodegenerative disease, which causes symptoms that are characteristic characteristic of dementia. What do we mean by neurocognitive disease? It means it causes a neurodegeneration or loss of neurons in the brain, specifically the cortex. So, coming to the neuropathology of Alzheimer's disease, we know now what Alzheimer's disease is. How exactly is this manifested in the brain? A definitive diagnosis of Alzheimer's disease requires the behavioral presence of dementia, which I will explain later on in the slides, and the identification of neuropathologic markers of Alzheimer's disease. So what exactly are these neuropathologic markers? The neuropathologic hallmark of Alzheimer's disease is the presence of neurofibrillary tangles and the formation of senile plaques. These two are often cited as the main causes for the progression of dementia. So what are neurofibrillary tangles? They are insoluble, meaning they cannot dissolve in the blood. They're twisted fibers found inside the brain cells. These tangles consist primarily of a protein called tau, which forms part of a structure called a microtubule. The microtubule helps transport nutrients and other important substances from one part of the nerve cell to another. In Alzheimer's disease, however, the tau protein is abnormal and the microtubule structure collapses. And when this structure, the microtubule structure collapses, it slows down communication from one nerve cell or neuron to the other, ultimately leading to cognitive deficits. What is amyloid plaque? It is a general term for a protein fragment that the body produces naturally or normally. In a healthy brain, these protein fragments are broken down and they are eliminated through a natural process. However, in the brains of Alzheimer's disease patients, these amyloid plaques are hard. They are insoluble accumulations of proteins that clump together between the nerve cells. So what happens? This is an image of what can happen to our brain cells. Both of these things, the neurofibrillary tangles and the amyloid plaques, when they work together, they disturb the integrity of the neurons, leading to cognitive deficits characteristic of dementia. The one in the top is the formation of plaques. The one in the bottom is how tangles are represented visually. So an examination of brain tissue at autopsy shows the accumulation of amyloid plaques and neurofibrillary tangles. But whether Alzheimer's disease evolves from neurofibrillary tangles and the presence of neurotic plaques, or whether they are byproducts of the disease process is unknown. So they are not certain which one is the cause and which one is the effect. So what exactly happens at the disease process of the Alzheimer's disease? How does it develop? And what is the course that a person goes through once they are diagnosed with Alzheimer's disease? Alzheimer's disease typically progresses slowly in 3 general stages. Some people may give up to 7 stages, so there are several different stages, but the one that I would like to mention is just 3 stages. They're called the early, middle, and late stages, sometimes referred to as mild, moderate, and severe in a medical context. Since Alzheimer's affects people in different ways, each person may experience symptoms or progress through the stages differently from one another. So the presence of individual differences in the course of the disease is evident through case studies. The different cognitive declines that occurs may vary depending upon the person. For some people, personality changes may occur earlier in the early stages compared to others where one might see personality stages towards the end, towards the late stages or the severe stages of the disease. The interval between diagnosis and that can also vary according to the person, but it can be as long as 15 to 20 years based on the research that has been done by Mizoram in 2000 and several other people as well. So what are the clinical subtypes? Clinically, Alzheimer's diseases can be divided into two subtypes. This distinction is made based on at what age the symptoms may first appear in the patient. So the first type is called dementia in Alzheimer's disease with early onset. This occurs before the person hits 65 years of age. And the second one is called dementia in Alzheimer's disease with late onset, when onset starts at age roughly after age 65 and later on. So what is the clinical presentation and the neuropsychological profile of Alzheimer's disease? The first clearly evident sign of cognitive decline is in the area of memory. In Alzheimer's disease, it globally and profoundly impairs memory. It first affects our new declarative learning, that is our ability to learn things that we can speak about. For example, the names of other people, the capitals of a state, all those things they have an issue with in the beginning. So this problem may be evident at all levels, whether it be in encoding, storage, retrieval, and retention over time. Later, structures of the brain that hold previously well-learned semantic knowledge information begin to deteriorate. For example, semantic knowledge would imply general world information, general world knowledge, the names of colors, the sounds of letters. All those things are later on affected. Finally, they have a difficulty in recalling names of their family members and also stories that they have told before. And also their short-term memory is affected. They're not able to remember things that were told to them just minutes earlier. The only type of memory that appears to persist is something called non-declarative memory, which includes our memory of doing specific motor things, like our ability to ride a vehicle, our ability to ride a scooter, for example, tying a shoelace. All those things are relatively quite well preserved. They only occur towards the later stage of Alzheimer's disease. The next area or cognitive deficit is in the area of language and speech. Early in the disease process, patients show anomic aphasia, characterized chiefly by word finding and naming difficulties. For example, a patient with Alzheimer's disease is more likely to say a tool instead of a hammer. They can use a pencil or a comb, but if you ask them what are these objects, they may not able to name them, even though they know what use they are for. Basically, they have a difficulty in naming these objects. As the dementia progresses, language problems become more profound and evident. Comprehension problems begin to appear. They start having problems in understanding what other people say. followed by problems in repeating information that is given to them. And finally, there is decline in fluent conversational output and may appear something that resembles global aphasia. They are not able to talk and converse with other people. They are not able to interact with other people. They seem to have a problem both in receiving and understanding the information given to them, the questions that they are being asked, as well as answering those questions, as well as producing the responses through speech. The next area is in the area of visual-spatial functioning. Visual-spatial problems appear around the middle stages of Alzheimer's disease if they do not happen before. So there is a marked visual-spatial impairments in their everyday activities. They have difficulty in orienting themselves to their environments, their neighborhood, even within their home. They're not able to locate where the kitchen is, where the toilet is. Okay? They have difficulty in locating which part of the state they live in, which part of the neighborhood they live in. On neuropsychological exam, they usually show poor performance on a number of visual-spatial measures. As in other functional domains, the degree of impairment corresponds to the stage of dementia. That is, the higher stage of dementia, the poorer their performance in several cognitive neuropsychological functioning as well as their everyday lives. Next is general intellectual functioning. Alzheimer's disease results in a decline in their general cognitive functioning. However, all these functions, they do not decline at the same rate. Some may appear to decline slower than others. So people with Alzheimer's disease do poorly on a number of tasks that require reasoning and problem solving, even in standardized neuropsychological tests. Crystallized intelligence is one of the few areas that remain preserved until the later stages of the disease. That is, their knowledges that they have acquired over the years, their experiences, the facts, and the skills that they have learned are better preserved than their ability to think abstractly, than their ability to learn new things, and their ability to reason or use reasoning. So the next clearly evident area is again in executive functioning. Deficits in this area is first evident for caregivers, that is, the people who are taking care of these individuals. They may be family members, they may be nurses in nursing homes. So early on, patients may start keeping notes to compensate for their memory loss, so as not to forget an information or to remember what to do. They might write down a list of things that they need to do and paste it on the fridge, put it on their bedside, all those things. Preservation of thought occurs often. Example, the person tells stories over and over again and asks questions repeatedly. So they might forget that they've already told the person one thing. So they might start telling them again and again what has happened. And also they are not able to remember the things that are told to them. So they will ask the same person, they will question them repeatedly, asking for answers that they have already received before. There is also loss of metacognitive awareness, the inability to self-monitor and control their own behavior and performance, and also their ability to behave in a socially appropriate manner. So they might start creating problems in family gatherings. Okay? All those things may start to appear. Problems in the ability to organize plan and use appropriate strategies for problem solving is another area that is clearly evident in patients with Alzheimer's disease. Next is in difficulty in orientation, attention, and LOC, also known as loss of consciousness. Orientation for person, time, and place is generally intact until the moderate to severe stages of Alzheimer's disease. The individual with AD may not be able to tell where they are when they have orientation problems. They may not be able to tell you what time of the day it is. Is it daytime? Is it nighttime? Or they may not be able to tell you who they are with. So even in the clinical setting, if a person is with Alzheimer's disease is brought to the session, if you ask them who they are coming with, they may not be able to tell you who the other person is. Selective attention or the ability to pay attention to one thing over another may persist late in the course of the disease. However, more complex forms of attention, such as giving divided attention and alternating attention from one thing to another, may decline even in the early stages of the disease. So they might have difficulty in multitasking, doing more than one task at a time. Those are things that appear very early on in the stages of Alzheimer's disease. Next is in the area of motor and sensory functions. Compared to other areas, motor and sensory abilities are relatively preserved throughout the course of Alzheimer's disease. Simple motor speed and strength, they persist late in the course of the dementia. These functions can be assessed using various neuropsychological tests like finger tapping tests, for example. And more complex motor behaviors such as coordination and skilled movement, these decline later in the course of the illness, such as ability to tie one shoe, ability to fix their neckties, and other jobs that require skilled movement. Olfactory or sense of smell is the only primary sensory area that is affected and compromised even in the mild stages of the disease. So loss of sense of smell is something which is clearly evident even in the initial stages of Alzheimer's disease. This loss of smell is also present in other dementias like Parkinson's disease. Next is in the area of mood, emotion, personality, and insight. Suspiciousness of others and frank paranoid delusions can manifest in memory dysfunction. So they may start accusing other people of stealing something from them. They might start accusing their spouses of committing adultery or infidelity. And also, due to memory difficulties, there may be the presence of increased irritability, and low frustration tolerance may also increase. They may be angry with their families over very small things and argue and start a fight with them over very tiny things. As memory becomes less reliable, a person concerned with order, timeliness, or organization much before the Alzheimer's disease started, may obsessively start checking dates, start checking doctor's appointments. They may start checking their medications, a list, and other things. So all these things, as you can imagine, all these changes in mood, their emotion, changes in their personality, may have an impact on their interpersonal relationships with their family members, with their friends. So overall, it might have an impact on the mental health of the families and even the society as a whole. So, which brings me to the last. These are the references that I have used for this presentation. APA, American Psychiatric Association, 2013, Diagnostic and Statistical Manual of Mental Disorders. Also, Neuropsychological Assessment Books by Lezak, Principles of Neuropsychology by Zillmer. So, to conclude, I would like to say that Alzheimer's disease is a neurocognitive disorder, a progressive cortical dementia that leads to decline in various cognitive functions as well as personality and behavior over time, such as memory, language and speech, visuospatial functioning, general intellectual functioning, executive functioning, orientation, attention, and loss of consciousness, memory and sensory functions, and finally, mood, emotion, personality, and insight. I will stop here for today. Thank you very much.